Good morning, everyone. I'm so happy to be here with you today talking about evidence, ethics, and quality. Three words that on their own describe concepts that are inherently desirable. I don't think I would get any debate on that. But try to put them together. And some people, maybe acknowledging the monumental task of simultaneously incorporating these concepts into healthcare decision-making, would call you an idealist, or even worse, an academic. And believe me, I've been called one. But I, and a few other people, and I think actually a great number of people, would say that these three concepts are essential elements of coming up with a healthcare system that provides quality and equitable care within a publicly funded system, a sustainable publicly funded system, such as that which exists in Canada and elsewhere. Indeed, these three concepts are also essential elements of health technology assessment, or HTA, and that's why I've got the subtitle of that presentation being Why the World Needs HTA. Let me just start with a quick story. And actually, I might jump down here because I'll probably trip. So imagine a summer day in Canada, June 2009. Canadians had just celebrated Father's Day, and hockey season for us had just ended. Yes, just ended in June. A family in Ottawa, Ontario, so where I'm from, welcomed their second son into the world. And even though he arrived a couple of months early, everyone was pretty sure that he'd do just fine. Nothing that a few weeks in a special care nursery wouldn't fix. Now, with all newborns who were born in the province of Ontario, a sample of this little guy's blood was sent off to the newborn screening program. This program had been expanded a few years prior, and at present it looks for about 30 serious treatable conditions, including PKU, MCAD, and congenital adrenal hyperplasia. So now imagine that you're the parents of this little guy. You've just come through an unexpected preterm delivery. You're now on that postpartum emotional roller coaster. That's accompanied by visiting the special care nurse three times a day to make sure that you're there for feedings. And you're also trying to maintain some semblance of normalcy for your older son, who's at home and who can't even come and visit his little brother in the hospital because H1N1 had just hit our radar screen. Now, 2 or 3 days into this little guy's stay in the special care nursery, the parents are told that he has screened positive for one of those disorders that the screening program looks for, congenital adrenal hyperplasia. Now, that's an inherited disorder of the adrenal glands, and it's treatable, but it will require lifelong medical or pharmacological treatment. So just imagine now how you would be feeling. Devastated, shocked, guilty, frustrated, helpless. Now, luckily for the family in question here, the story has a happy ending. The medical professionals in the special care unit actually downplayed the results of that screening test from the very beginning. They had said, based on how the little guy looked and behaved, it was very likely that this was going to be a false positive. And certainly that's how it ended up working out. But for those 2 or 3 days when those parents were waiting for confirmatory testing, they were in pretty much emotional agony. And certainly now, no one is worse for wear. And in fact, the little guy in question is a happy and healthy 2-year-old who just loves to play alongside his big brother and who loves for his parents to read and reread the same Thomas the Tank Engine book over and over again. Now, you might be asking what this story has to do with evidence, ethics, quality, and HTA. Well, the evidence that is out there in terms of newborn screening programs, I know we could always get into a bit of a debate about this, but it is pretty clear in terms of clinical and cost effectiveness. As a result of these programs, we're now able to diagnose at birth many serious medical conditions that then can be treated, and that thereby prevents substantial morbidity and mortality. Then, because we're dealing with a screening program, there are, of course, a whole host of ethical issues that warrant serious consideration. First and foremost, is it ethical to screen for a condition for which there is not yet an effective treatment? In the case of a newborn screening program, what about the ethical imperative of autonomy when the subject of the screening program, the neonate, can't offer explicit consent? What supports are in place for families while they're awaiting the test results and thereafter? What are the odds of coming up with a false positive or a false negative? And then, of course, how quickly can confirmatory testing occur when there is an initial positive screen? Well, you've already seen it here, but the answer is perhaps HTA. With all of that, by looking at evidence, including those ethical considerations, we'll get at quality care for the patient and his or her family. Now, there are a lot of HTAs that are already out there, and that's probably not a surprise to you. Indeed, there was a flurry of activity 6 or 7 years ago, I would say, with my agency, as well as the NHS, initiating HTAs on newborn screening programs in response to the introduction of tandem mass spectrometry, or tandem mass. Most of those HTAs did look at the evidence, clinical, cost, and ethical. And it's those ethical issues that are so critical to the implementation, the successful implementation of any screening program. Now, some food for thought here, and a hot off the press article in the current issue of the International Journal of Technology Assessment in Healthcare. This one by Fisher actually looked at HTA, the involvement of HTA in decisions around newborn screening in 11 EU countries. No surprise, when there was an HTA report, they were able to find an association with decisions as compared to decisions made without an HTA report. But Fisher's work went a little further and actually found the process of decision-making differed by the existence of that HTA, with decision processes based on HTA having greater involvement of stakeholders, broadly defined, and also being more transparent insofar as decisions were documented. So you've got evidence, ethics, quality, inclusivity of stakeholder perspectives, and transparency. All pretty good things, I would say, in terms of doing HTA, but also in terms of decision-making within a publicly funded system. Now, for those of you who haven't been over to visit us in Canada, I'll just take a minute or two to tell you a little bit about us. We're a pretty big country in terms of geography. About 34 million inhabitants scattered across 10 provinces and 3 territories. Our population is aging, and the latest data suggests that within the next 25 years, the number of seniors in Canada is going to double. And they, by that time, will comprise a quarter of our population. Keep that in the back of your mind when we're talking about our healthcare system. It's probably not a surprise to you that with a universal, publicly funded healthcare system that covers hospital and physician care for all Canadians, we spend a fair bit of money on that system, $192 billion in fact, and that equates to about 12% of our GDP, or if you're looking per capita, over $5,000 per person. What might come as a surprise to you, and if we had those little clickers that we used in the other room, I'd get you to vote on this, but we do not have one Canadian healthcare system. We have lots of systems within Canada, and I could probably spend the next week with you trying to explain it. And I would get it wrong because I have lived there for 40 years and I myself don't quite always understand how it works. Suffice to say, it's complicated. Decision-making within the Canadian system is decentralized. The federal government, based in Ottawa, where I'm from, is involved, as are each of the provinces and territories, as are health regions within each province and territory, as are the hospitals within each health region, within each province, within the country of Canada. So complicated. And nary a day goes by when there's not media coverage that is highlighting apparent disparities in our system related to what's covered in one part of the country versus what's covered elsewhere. I should also take a second just to explain my home agency to you, the Canadian Agency for Drugs and Technologies in Health. Now, we've been around a little over 20 years, and we're similar to your NICE insofar as we do HTA on drugs, devices, procedures. But unlike NICE, the advice that we give is not binding. So we put it out there, and we hope that someone will listen to us. Now, it is a little bit more than hope someone will listen, but again, it's not that binding evidence that you might find elsewhere. That being said, what I'm talking to you today about really, I believe, reflects HTA universally. Sure, the stories I'm going to tell you are Canadian, but the thesis of my presentation, that evidence, ethics, and quality are essential to HTA, and that HTA is essential to the delivery of quality and equitable care in a publicly funded system, I think that is fairly universal. Now, many of you are likely familiar with INATA, the International Network of Agencies for HTA, and this is their definition for health technology assessment. I won't read it through to you. I'll give you a second just to digest it. But really, what it's saying is HTA is there to support policy. It's supposed to look at lots of implications, not just the medical or the clinical, that is, does it work? Does that technology work? Not just the economics, that is, does it provide value for money relative to alternatives, but also the ethical, the social, and other ramifications of that technology. HTA, in theory, is to bring it all together. You might have heard the ethical and social and other issues referred to as ELSIs, E-L-S-I, and then a little s. So ethical, legal, and social implications of healthcare or health technology assessment. So again, part and parcel of HTA. HTA being evidence, all sorts of evidence, broadly defined, including ethics. But do you know what happens in reality? We don't do a very good job. We in the HTA business do not do a very good job of looking at ethics. And I'm not here to be advertising the International Journal of Technology Assessment in Healthcare, but it was quite interesting that the issue that came out last week contained 2 articles that are relevant to my presentation. The first one I'd already mentioned was by Fisher, looking at newborn screening in EU countries. And the second one that came out was by Sarney, and it was looking at ethical analysis in HTA. And you know, there are countless papers out there that suggest that the usefulness of HTA is improved by including ethical analysis. Most of us in the room would inherently agree with that. Common sense tells us that a technology is never adopted in a vacuum. Some technologies carry with them morally relevant consequences. Some of those technologies are going to push boundaries, challenge society. And even the HTA process in and of itself we're making decisions as we do that HTA. Many of those decisions themselves are value-laden. Data suggests that 80 to 90% of HTAs out there, even those done in the last decade, still do not look at the LCs, the ethical, legal, and social issues. Now, I don't think any of us would say that that absence of evidence as to the inclusion of ethical analysis in HTA means that we are insensitive to it or that we believe it should be disregarded. In fact, I would say that what we have going on here is that the very nature of making decisions in our systems has pushed us toward this lack of attention being given to non-clinical, non-economic, i.e. non-quantitative aspects of HTA. And even Sarni in this particular paper has said, a lot of people, they just don't know. We don't know how to handle ethics or do an ethical analysis. Do we even know that there are many ways of doing it? What are the pros and cons? Admittedly, these ethical issues are harder to get a handle on. Most of the time, they're a little softer, a bit more quantitative. And so sure, maybe we just don't know how to handle them. But I would also say, and this is based on my own experience over the past 5 or 6 years, that this pressure that we're under to deliver our reports faster means that we're ignoring the LCs in order to save a bit of time. But you know what? If truth be told, it's probably those ethical issues that matter most to people. It's what gets their attention. It gets the media's attention, it gets politicians' attention. And that, of course, assumes that the technology is safe and it works. So everything else being equal, it's going to be some sort of emotional response that gets people's attention. And in fact, this slide illustrates the point. A deputy minister of health back home has said something to the effect of, emotion will trump evidence any day. I initially took that at face value, but then I got thinking about it. And I thought, you know what? If a decision is getting people emotional or making them emotional, eliciting a response, isn't that in and of itself some evidence that needs to be considered? There's likely something behind that emotion that's driving people to react in that way. It could be, and I'm speaking in terms of the Canadian situation, it could be that we feel as a society that one particular part of the population is going to be getting the short straw, if you will. It could be that a particular decision that's going to be made looks like it will exacerbate existing health disparities. It could also be, and I think Peter and I were talking about this earlier, and maybe Stephen too, that the evidence that exists out there, the clinical evidence, really has nothing to do with what matters to patients. So whether those outcomes that have been measured, do they matter to patients? Does an HbA1c level matter? Or does it matter that the person gets to live longer with a higher quality of life? So dollars to donuts, what is going on when there's an emotional response, an adverse reaction to a decision, is that there's something ethical, legal, social implications of those technologies that's driving that. And I would argue that we need to be paying attention to that because that is what is true to the definition of HTA. Now you'll see on this report card here that I've given people A's in terms of everything except for that attention to the ethical, legal, and social issues. Again, reflecting that the overwhelming majority of HTAs fail to look at these issues. But what does it do when an HTA agency like mine has to prove to its masters, its funders, that we are delivering a return on investment for all the public funds that go into our work? Certainly, having people aware of us, having them aware of a report are good things. And again, remembering that our advice is not binding. But it sure makes it a lot easier for me to demonstrate return on investment when decisions out there align with the evidence we've put out in our report. But again, do you know what happens? Decisions are going to be made that don't always align with that evidence. And that's going to be reality. This happens no matter how well done that report is. But I would actually advocate for the fact that if we do pay better attention to those ethical, legal, and social issues, by incorporating them into that HTA, again, those are issues that are evidence, we will have an increased value, or HTA will be of increased value to the decision makers. And as a consequence, will increase the likelihood that decisions will more align with that evidence. So let me conclude and wrap up with just one more story, and you'll see the picture there of an MRI. Now this story stems from a request that we received from one of the provinces in Canada. They came to us and said, could you guys look at the evidence in terms of the safety and clinical effectiveness of a couple of different types of MRI scanner? The ones that they were looking at, one of them was of a higher magnetic field strength. I don't want to give the actual numbers because this then will give away which province it was, so I'm kind of trying to protect the identity of the requester. But they wanted to know, should I buy the stronger one, or should we stick with the tried and the true? And not only did they ask us to look at the evidence, they asked us to strike an expert panel that would come up with guidance about purchase and use. So that's pretty standard for an HTA group. We had no problem in doing that. The timelines were pretty fast, but we were able to deliver. But you know what? That wasn't the whole story. What had gone on prior to this was that the province had announced they were going to buy 4 new scanners. They went out and said 2 are going to be of the higher magnetic field strength, i.e. more advanced, more expensive. That's how it was reported in the media. The other 2 were going to be newer varieties of the existing commonly used field strength. Now, MRI machines are pretty big capital expenditures. So if you're going to make a purchase, it's going to be with you for a while. So you don't want to make that decision lightly. And I'm not saying that these people were going to do that. But as you might guess, this whole decision got a lot of people's attention. And why wouldn't it? Especially in Canada, where this universal publicly funded healthcare system is pretty much tied to our national identity. Kind of, we like to go around the world thinking we've got this great system. How could this be happening in Canada? Why was this one region of this province going to get the more advanced, more expensive technology, and then those of us over here were going to get the existing technology? How could that happen? Who made that decision? Who was consulted? Well, here is where evidence comes to the rescue. Now, we could probably have an offline discussion about the evidence in terms of the safety and effectiveness of MRIs. It's really not a great body of evidence. What people have looked at is image quality and scanning time. Don't think that really makes a difference to patients. So a lot of decisions are informed by that. But when we did take a look at the evidence in terms of clinical outcomes, clinically meaningful outcomes, it wasn't there. There was nothing there to suggest that the more expensive, more advanced scanner offered anything more to patients. So the province in question, based on the evidence, then also realizing, because of the media and the media attention and the public outcry, so some part of ethics, equity and whatnot, they decided not to go ahead and buy those 2 more advanced units. They said, we're not going to do it. Instead, we're going to buy 8 MRIs of the magnetic field strength that was already in routine use. And by doing this, they were able to replace some older machines, but also provide machines in areas that had been previously underserved. So that improved access to the scanners. allowed people to get care closer to home, and actually allowed more people to get through the system, which the province said meant something in terms of quality care for their citizens. So at the end of the story, I hope I've been able to share with you two things. The first is that evidence, ethics, and quality are all inherently desirable components of HTA. Those ethical, legal, and social issues, those ELSIs that are often ignored, are actually the things that may be most important to decisions and to decisions in a publicly funded system. The second point, which might be, maybe I'm going out on a limb here, but I would suggest to you that in a publicly funded system, like we have in Canada, like you have here, it's inherently unethical to be making resource allocation decisions without doing something along the lines of HTA. And I have to credit a colleague of mine, Brigadier General Hilary Yager, back home, who put it this way. She said, the opportunity cost of wasted money is someone else's QALY. And that someone else should have equal access to our collective resources. Knowing that I, or my husband, or another loved one will one day be that someone else, I can only hope that evidence, ethics, and quality remain cornerstones of our healthcare system. So thank you.
Thank you. That was a wonderful talk. Very powerful. Do we have any questions in the room? Maybe I'll start with the first
Sure.
one. So how can you bring patients into this formula with HTA?
That's a really, really great question. And certainly, I'll hang my head a bit in shame and say that Canada is not a leader in regards to patient involvement, at least with our agency. Some of the provincial HTA agencies in Canada have struck citizens' councils or citizens' juries, whereby you're bringing together a better cross-section of the population to actually deliberate about what outcomes are important, what technologies are deserving of an HTA. Having patients and public members involved in expert committees is another way we've been able to incorporate that process. But certainly, I mean, there's a lot of room for improvement. And I mean, what I tend to see is involvement of patients near the tail end after you've done your report, and then you bring them to the expert committee and say, what do you think? That's probably too little, too late. Having them involved up front in the prioritization of topics, in the selection of outcomes, what levels of evidence do you want to look at? I think that's where we need to go. Because otherwise, you know, they kind of are on the receiving end of a report, and you kind of know what you feel like. I mean, Stephen's example on how you feel when you're simply told this is what you need to do.
Yeah, I just wanted to ask your opinion or make a comment about the issue of delay in dissemination of technology when you add yet one more dimension to the assessment. Because, you know, if you go back, insulin from the time of discovery till the time it was, you know, disseminated was 2 years, you know, at the time of Banting and Best. And now it takes over a decade for technology to be disseminated. So, and the second point I just wanted to make or get your opinion is, I think there's something else we have to put into the LC, and that's politics. And I wanted your opinion about that.
Great questions. And certainly in terms of greater involvement of the public in our work, with our common drug review that's actually housed at our agency, it has very clearly prescribed timelines. And without getting into how things work in Canada, Health Canada is our regulator. So they actually look at safety and efficacy typically versus placebo. So they're like your EMA, I would believe, in terms of what is allowed into the country. Then there's an extra level or an additional step, HTA, where we actually look at what's reimbursed by our various public plans. The industry, the pharmaceutical industry in particular, is very concerned about the length of time it takes to get things onto the Canadian market. So if you're looking at Health Canada approval, and then we do our review, and then we pass on that recommendation to a province who, might take a little while to make a decision. We're looking at, things that are not done in tandem. You've got them going on consecutively. When we have gone forward with a suggestion to increase the involvement of public in our work, the industry has said, sure, but don't you dare change your timelines. So if you can do things within that existing, 5 or 6 month time frame, go for it. Go for it. Fill your boots. But please do not change those timelines. And this is the challenge that we're facing. We also realize how quickly things are done elsewhere in the world, so we're often being, benchmarked against that. What we've tried to do in Canada is actually start to make the regulatory and the HTA decisions be occurring simultaneously, or at least to stagger the start, so that when Health Canada is looking at a particular technology and it looks like it's going to be favorable, we could start our review. The issue is that the current legislation in Canada does not allow Health Canada to tell us what they're looking at. So we have been a little creative and have found a way to figure out what they're working on. And this is, if we call up our colleague over at Health Canada and say, are you working on drug X? And they say no. That means a no. So I'll call them up a month from now and they'll say no. That still means no. Call them up a month after that and they say, I can't tell you. That means yes, they are. And then I might be able to start working on that review. What we've realized is that it's very difficult to change legislation. So we are in fact trying to work regulator, HTA agency, and industry and get industry's agreement. If industry agrees that Health Canada can share information with us, certain amounts of information, then we can make that happen. So we do have a couple of pilot projects that are on the go right now trying to see how much time we can save. Because at the end of the day, we don't want to be yet another obstacle that is delaying access to effective treatments. In terms of politics, I couldn't agree with you. I couldn't agree with you more. We've just come through a month of October that had, I think, 6 of our provinces had elections. Back in the spring, our federal government had an election as well. And so what you tend to see is a bit of this silly season. I don't know what you call it over here, but in the lead up to an election where people are hoping to get reelected, they will spend money in a, let's say, how do I say this so I'm not going to get in trouble, in a way that is not necessarily as evidence-based as it could be. So couldn't agree more. The question is, do we put it in and call it a PELSI, or is it an ELSPI? Where do we fit in that P? Let's talk after this session's over.